Most patients with superior oblique palsy require surgery. Non-surgical treatment is indicated in cases where patient with mild paralysis of the superior oblique muscle, 10 diopters or less, especially older persons who are used to wearing glasses, often do well with prismatic correction. Although this treatment is not likely to eliminate diplopia in all fields of gaze, the patient may acquire sufficient visual comfort to avert surgery. A translucent adhesive tab, which is called a sector occlusion of the lower segment, may relieve diplopia that's limited to the reading position without interfering with single binocular vision in the primary position. Surgical treatment of superior oblique palsy is based on prism cover measurement findings, the torsion, and the results of superior oblique traction test. Hatched areas shown in the diagrams on the following slides represent the field of greater deviation. This scheme was described by Knapp in 1971. Class 1 superior oblique palsy. Overaction of the antagonist inferior oblique with deviation about 20 prism diopters or less in the field of action of the antagonist. This is a common pattern for both acquired and congenital superior oblique palsy. Surgery for class 1 is to weaken the antagonist inferior oblique. This is the safest surgical procedure for any superior oblique palsy. Class 2, under action of the paralytic superior oblique, with the deviation greater in the field of action of the paralytic superior oblique. This is best treated with prism and time. A larger angle deviation with this pattern can occur in congenital absence of the superior oblique tendon. If a pattern like this emerges in a congenital superior oblique palsy with facial asymmetry, as in this gear, superior oblique traction test followed by exploration of the superior oblique will lead to the appropriate surgical plan, which could include superior oblique tuck, inferior oblique weakening, or Uke inferior rectus weakening, depending on the angle and the state of the superior oblique. Class 3, in this case, the deviation is equal in the field of the paralytic superior oblique and the antagonist inferior oblique. Surgery. If the deviation is less than 20 prism diopters in the field of the greater deviation, only the antagonist inferior oblique weakening is done. If it is greater than 20 prism diopters and the superior oblique traction test reveals a lax tendon and a congenital superior oblique palsy is diagnosed, attack of the superior oblique can be performed. If the superior oblique tendon is tight, the Uke muscle, the contralateral inferior rectus, is recessed. Class 4. This common pattern of hyperdeviation, which is class 3, demonstrates a spread of hyperdeviation across the bottom, occurring because of tightness of the ipsilateral superior rectus. If the deviation is 20 prism diopters or less, weakening of the antagonist inferior oblique and the ipsilateral superior rectus is effective. If the deviation is greater, the superior oblique tendon can be tugged if it is loose, or the Uke inferior rectus can be recessed if the superior oblique tendon is normal. Class 5. Hyperdeviation across the bottom can be the pattern in a long-standing acquired superior oblique palsy. Surgery. If the vertical deviation is around 20 prism diopters, the ipsilateral superior rectus is recessed, and either the superior oblique is tugged, the yoke inferior rectus is recessed, or the ipsilateral inferior oblique is weakened. Class 6 is bilateral superior oblique palsy. This condition is characterized by history of trauma, spontaneous torsional diplopia, usually is greater than 15 degrees torsion with double Maddox rod testing, and the presence of V pattern and reversing Bolshevsky head tilt test. There is a little agreement among experts when it comes to surgical treatment of bilateral superior oblique palsy. Bilateral weakening of the yoke inferior oblique is favored by some to treat the V pattern and the torsion. Others do a bilateral recession of the inferior recti. Class 7, what's called canine tooth syndrome, or Brown syndrome with superior oblique underaction. This condition is characterized by history of trauma to the trochlea with mechanical restriction in up gaze and down gaze, trauma to the trochlea restricting up gaze, and residual superior oblique palsy restricting down gaze. It can also occur as an iatrogenic Brown after superior oblique tuck with residual superior oblique underaction. This problem is difficult to treat. Surgery described by some authors are none, if eyes are aligned around the primary position. Secondly, yoke inferior rectus recession if ipsilateral hypertrophy. Third, take down the tuck if it is iatrogenic. Lastly, free superior oblique restriction if ipsilateral hypertrophy.